Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. I'm honored to introduce our mentor for today, Dr. Khaliq. Dr. Khaliq attended the University of Maryland at College Park for predoctoral studies and graduated with an honor citation in general biology. He obtained his Doctor of Dental Medicine, DMD degree from the University of Pittsburgh School of Dental Medicine, as well as his specialty training in endodontics. His dedication to research has earned him an appointment as adjunct faculty at the Graduate Endodontics Department at the University of Pittsburgh School of Dental Medicine, where he continues to pursue research interests in his spare time. Now I'd like to request Dr. Khaliq to start today's session. Thank you.
All right, good morning. Can everyone hear me?
Yes.
Okay, perfect. So thank you so much for having me on here. As I mentioned, I am an endodontist, which is a field that is not usually discussed very much in dentistry. There are actually 9 specialties in dentistry. Among them, I guess the most common ones we hear of are orthodontics, basically braces, alignment of teeth, your bite, pediatric dentistry, possibly you may have heard of. You may have heard of oral surgeons, but you really don't hear about endodontics unless you really need a complicated root canal. So I'm here to discuss that with you, my journey, why I chose this field, why I enjoy it, why I see myself doing this every single day for the rest of my life until I retire, and what about it is pleasurable besides just doing the root canal itself. So let's get started. Let's start the video. Here we go. And how do I make the slides go forward? One second. Here we go. So what I'll be discussing, I'll first be doing a quick specialty overview to tell you exactly what the specialty is about, what we focus on. Then I'll discuss my background, why I chose the specialty, my educational background, and also what experiences led me to believe that this was something for me. My journey in my career, currently my practice, what I do in a day-to-day, so you can get an idea of what it's like to be working as a clinician in endodontics. And then a few cases that I've recently done. I've just recently moved my office, so I don't have access to many of my cases right now as we port everything over, but I do have a few cases from the last 2 to 3 weeks to show that I want to share with you. So let's first start with the overview of the specialty. Endodontics, the words, is a branch of dentistry concerning the dental pulp and the tissues surrounding the roots of a tooth. So endo is the Greek word for inside. Odont means tooth. So we are only focused on the inside of the tooth. If you look at the diagram towards the right side, the clinical part of the tooth that we actually see, the enamel, is actually a very small part of the tooth. Under that is a dental pulp, which is the hard tissue that is actually innervated by nerves and the stuff that we can actually sense. So whether it's cold stimulus, hot stimulus, or some damage to the tooth, that's where we feel it because the nerves are innervating that portion of the tooth. The vast majority of the tooth that we don't see is the root that's embedded inside the bone, and it's surrounded by a soft tissue periodontal ligament. So when we percuss or tap on that, if it's painful, sensitive, that ligament is what is giving us that stimulus. If you look at the very bottom of that tooth, there is a root end opening, which is called the root apex. That's from where it communicates with the rest of the body. That's where the blood supply, the nerve supply gets into the pulp tissue. The pulp tissue, the little red part inside the tooth, is actually very small, but it causes big amounts of pain and discomfort should that be disturbed in a certain way. So as I said, an endodontist is a specialist that focuses on saving teeth. So there's 2 ways of getting rid of pain, discomfort, of abscess when you have a tooth issue. One way is more aggressive, which is to remove the entire tooth. That will certainly eventually get rid of your pain and discomfort. Or we can save the hard tissue, the tooth itself, and just remove that really painful tiny part inside, which is the pulp. So when we remove the pulp and disinfect everything and clean it and seal that with a small root canal filling to prevent future infection, that is a root canal procedure. So let's talk a little bit more about that now that we have a basic understanding. So typical reasons for requiring endodontic treatment. First, again, let's compare a healthy tooth at the very top to the one at the bottom. So the tooth at the top, it looks nice and sound. The one at the bottom, there's a big cavity there. If the cavity is very small and nowhere close to the nerve, it does not usually require endodontic treatment. There's no contamination of that nerve space. We just clean out the small cavity. That's called a filling. We clean the cavity out, we seal that, and the tooth is back in normal function. However, if the cavity gets very large or the bacteria, which is in the cavity, reaches that nerve space and causes contamination or inflammation, that causes severe pain. Eventually, bacteria continues to travel down that route into the bone, and that's where we see an abscess, pain, and swelling. So those are all reasons for requiring root canal treatment. So extensive caries into the pulp tissue, extensive cavity or caries, it's the same thing. That is the main reason we see most of our cases. The second reason is when the cavity is so extensive and has been left there for many, many months, weeks, years, whatever the reason might be, the patient has not sought care, it eventually travels into the bone and becomes an abscess. Many of these patients have severe pain and swelling because the bone is now infected. And antibiotics themselves will not cure the issue because antibiotics cannot go inside a dead tooth. Once the tooth is dead, there's no nerve in there. So yes, we can keep hitting you with antibiotics to clean the bone out, but we can no longer address the issue unless we actually drill into the tooth, clean out that damaged or destroyed tissue, and seal it properly. The third reason that we see very often, mostly with children, is dental trauma. And that's mostly with your front teeth, teeth that get chipped and damaged to the extent where the pulp is exposed, or even if the pulp tissue is not exposed, but is cracked and leaking. Those are all reasons for taking care of the nerve and saving the rest of the tooth. Another dental trauma is when the root gets cracked. Many of these teeth are still savable and require intervention by an endodontist to make sure that we can save this cracked root so the child can continue normal bone development around that tooth into adulthood. Dental abnormalities or lack of tooth or root apical development. So the first part that forms in a tooth is the crown, the part that we see on the outside. That forms first and erupts first. Under that is the root. So when the tooth is forming, the root is forming at the very, very end. So if there is some kind of insult or damage or cavity or trauma to the tooth during development, the root is going to stop forming and it'll be malformed. So that is one reason for an endodontist to intervene to ensure that the tooth continues to grow. That is called a revascularization procedure. It's a very recent thing that we do. So kids that we see who are lacking this proper development, we intervene and ensure proper root and therefore bone and body development. And the last reason is for restorative purposes. So let's say the nerve is still healthy, but the tooth is cracked in a way where the crown can no longer be placed on it. And another specialist, such as a prosthodontist or implant specialist, says, hey, I need the root canal so that I can use or shave this tooth down in a certain way where I can put a crown on it. So yes, that's called an elective endodontics procedure. It's not necessarily required. There's no pain, there's no symptoms, but there's no other way of putting this tooth in function besides just doing the root canal. So those are the 5 main reasons that I see patients for endodontic treatment. So why would you choose an endodontist over a general dentist? So the first thing, there is definitely much confusion in terms of seeing a specialist. We know that most dentists do root canals, most dentists do orthodontic braces. We know they do most of these things. So why don't we just go to them and get a cheaper price? So the answer is yes, and the general dentists are great at what they do. The vast majority of procedures, or root canals even, are done by the general dentist because they're relatively straightforward and have predictable results. But if the procedure is complicated or you anticipate issues happening, that's when you want to choose an endodontist, because we do this day in and day out. We have more advanced education, we have specialty training, we have specialty expertise. In our training, we have experienced many, many cases that a general dentist will never see in their practice. So we know how to tackle these correctly and receive better treatment outcomes for more complicated cases. Another reason for seeing the endodontist is pain management. So we are specialists in pain management. So the patient has a severe abscess, severe pain, severe swelling, or a hyperactive pulp from repeated insults or trauma. You definitely don't want the dentist to just see you as if they're seeing you for a filling. You want to come in here, be properly anesthetized, properly calmed down, possibly sedated, and then have this taken care of. So it's a much less traumatic procedure. It's much more predictable with the endodontist when it's a complicated case. That is a good reason to see the endodontist. And the last reason I would say is the use of cutting edge technology. Recently, in the last 15, 20 years, our specialty has grown a lot with technology. So one of the main things we do is we now use microscopes for every single case, whether it's for surgeries or for regular root canals. And because the tooth has many, many canals and everyone is different, one of the main reasons for failure of root canal treatment is not finding all of the canals, or if you find all the canals, not cleaning all of them properly. The tooth is very small, so the nerve is even smaller. If you're not able to locate all the canals and all the anatomy and obturate or clean and disinfect it correctly, you are setting yourself up for eventual failure. So that is one reason to use us. Another technological reason is the use of imaging that we have now. So yes, there are very basic x-rays as dentists take. And yes, dentists are also investing in many, many ways to advance that. But we use CBCT machines, so which basically helps us take a three-dimensional scan of the tooth. So cases that, let's say, have failed the first time, and we're looking at the x-ray, we can't tell why it's failed. It looks beautiful in 2 dimensions, but of course the patient's having symptoms. It's clearly not healing anymore. What's the reason? See an endodontist, get a CBCT scan, have them read it, check if there's any anatomy that's been missed, or maybe there's a crack inside the tooth. If there's a crack there, it might not be savable. So you redoing the case again and again, investing time, money, and being in pain for that time, we can give you a better answer. We can diagnose and put you on the right track. Okay, so those are some of the main reasons that to choose an endodontist. Now, in my opinion, the best 2 reasons to choose an endodontist is number 1, diagnosis. A success of a procedure is only as successful as its diagnosis. So one of the main things I see with dentists, because they of course don't see these cases every single day, they will refer the patient to me, and they will usually, thankfully, they will usually put a suggestion there. They'll be like, I think it's this doctor, but you take a look. So every patient that I bring in, I always do an exam. I want to diagnose it correctly, and because that's going to set us up for good treatment outcomes. We don't want to misdiagnose and mistreat the patient. So one of the main reasons to see an endodontist is to diagnose everything correctly. And the second, as I said, is the complexity of the procedure. Yes, a dentist is trained to do root canals as well, but with complex cases, you investing your time and money in your body, you really want to make sure that, yes, complications will still happen, but you want to make sure you set yourself up for the highest chance of success. Okay, and the next slide. Oops. Not too good with PowerPoint, I'm sorry. There we go. So let's discuss a little bit of my background, what basically led me into healthcare and then into specifically dentistry and endodontics. So I had a healthcare focus since high school. My mother is actually a physician, and she worked at multiple different hospitals and also tertiary care facilities. And I didn't know if I wanted to be a doctor, a dentist, or something else. So it's good to explore. So in high school, I went and shadowed at many of these facilities, nursing homes, tertiary care facilities, and hospitals themselves. And that, while it showed me that I did not want to work, overnight and do things like that, it did show me that I would love to be somebody who's having that one-to-one patient interaction. I saw that I would possibly like doing procedures, but not necessarily what my mom was doing. So that was my first exposure to healthcare. After that, when I was an undergrad at the University of Maryland in College Park, I had a very big science focus. I wasn't sure where I wanted to be, but I was looking at, even like mammalian physiology lab or all sorts of courses to see what I'd like to do. And I noticed very quickly that I did not like dealing with cutting up tissues and blood. I liked a very clean field for my procedures. So that further led me into dentistry versus medicine, more towards dentistry. My sister's a dentist as well. So she also encouraged me to shadow and explore. So during my undergraduate career, I went to shadow at many different general dentists. I also worked for one as an assistant, get my hands dirty and see what it's like, which I encourage you all to do. And that pointed me towards that direction. I definitely like dentistry. So I was admitted to the University of Pittsburgh School of Dental Medicine. I did my training over there. And while I was doing that, I initially had more of a genetics focus, but during research and clinical experiences, I decided that endodontics residency for me, I was very happy to match there right out of school. and I finished residency over there. So let's talk a little bit more in detail about these things. So first, in my undergraduate studies, the things that I have learned, and I encourage you all to do, is to explore and see what you enjoy. It's very important to look like a well-rounded applicant, yes, but what you're eventually leading yourself towards is a career choice, and we spend a vast majority of our day at work. So we should be happy with what we're doing. We only produce our best results when we're happy doing it. So explore and see. Don't just listen to somebody else in terms of what they think you should be doing. At least give your chance to explore your options. So like I said, whether it's in classes, whether it's shadowing, going to different jobs, picking up part-time jobs or experiences, or talking to professors, faculty, or people in their professions who are actively doing this, talk to them and see if it's something you see yourself fitting into. So asking questions, very, very important. And also with that, as you progress in your undergraduate education, listen to yourself. Does this fit with you? Is it stressful? Is it something you enjoy? Is it something you want to pursue? For me, I wasn't sure exactly what I wanted to do, but I knew healthcare focus was something that I was definitely into. And in undergrad, I continued to narrow that focus into dentistry. So then again, advice for students who are in undergraduate, figure out who you are now, because you don't get to, you can keep trying again and again and waste your time. But at the end of the day, you need to make sure that you're happy with what you're doing. So learn what helps you focus and be productive. I only say that because the first year of undergrad, high school is such a structured environment. It's fantastic for me. It really helped me do what I was doing. But from that, suddenly undergraduate studies, especially now with the pandemic, it's very destructured. So it's very easy to get lost, very easy to listen to too many opinions and not listen to your own. So learn what helps you focus, what helps you be productive, and give yourself time for that. But in the same way, go out of your comfort zone a little bit. You may think that you've heard of something a lot and that works for you. But like I said, I thought that healthcare certainly was something that I wanted to do. But I did go out of my comfort zone, listen to my sister, listen to some other dentists, and it helped me realize that possibly dentistry is where I want to be and not specifically medicine. So yes, focus on being well-rounded for your application. Schools are looking for that, but also focus on what is sustainable for you for a lifetime. Focus on what makes you happy. In the application process, it might look good, but schools can see through people who are just doing things for the application versus people who on interviews talk very passionately about their experiences and are able to project themselves as, this is something I want to do. I've done this already. I've talked to so-and-so people. I've shadowed here. The passion really shows. So learn how to talk about it, and you'll only do that if it's something you really want to do. So let's talk about my dental school experience at the University of Pittsburgh. I initially had a very heavy research focus. And, like at that point, I guess that's still a very big buzzword, genetics and things like that. So that's where I focused my initial research, and it involved me in a lab that I really did like working at, but genetics ended up being not something I really, really liked. From there, my mentor I guess he sort of saw how I like to work in terms of classes, where I was progressing, what I enjoyed, and he sort of pushed me towards endodontics. So much of my research ended up being in endodontics with a genetics focus. I published 5 papers over there. I was definitely enjoying my work. In addition to that, yes, doing well in class is important, but you also need to go shadow. So I made sure in my 3rd and 4th year to go to the endodontics department where there were residents and faculty. And I used to sit there, talk to them, look at what they were doing, see if I could see myself in that position, ask a lot of questions about their day-to-day, what cases are like, look at those cases and discuss things with them clinically. So whatever you're learning, you should be able to apply at some point. And talking with people who are in the profession or heading into that profession does help mentally place you, do I want to do this? Do I want to apply or not? And like I said, the dental school provides a lot of clinical experience as well. It's somewhat limited because the experience has to encompass all fields of dentistry, so you don't get too much endodontics, but excuse excuse me. But it's important to use that clinical experience to gauge, what I enjoy. And as I said, even from high school, I did not enjoy, cutting, suturing, and all those things. I also realized I hated most of dentistry. I hated restorative work. I don't want to do fillings. I don't want to do crowns. I don't want to do dentures. I don't want to do cleanings. I don't want to do any of that stuff. What I really started to enjoy from the very beginning was endodontics. And we'll discuss more on what that is, but that's how I focused on that. So I applied to residency. I got in the very first time I applied. I was very happy about that. And let's talk a bit about my residency training. So residency was great for me because it had a very heavy clinical focus. I was in one of the 4 programs that are only 2 years long versus 3, so it's an accelerated program. And they had a very high clinical focus on that program. So I've been to many conferences, talked to people doing residency, and I realized that I was seeing many, many more patients than possibly some of these other programs, which is great because I did want to be a clinician in the end, not a researcher, not a teacher. So that clinical focus was really good. It helped me see a very wide variety of cases, and the patient interaction does help you grow. So that's something you want to do in residency. The really good thing about my program as well was working with specialist faculty. Yes, it's important to be on good terms with your program director and the full-time faculty there who are teaching you, but keep in mind these people, their main focus is on teaching you. They are not outside. They are no longer working with patients. So they may or may not be able to give you a good idea of what it's actually like to be a clinician in the outside world. So what I loved about my program was that there was part-time faculty that were there 1 to 2 days a week teaching us, mostly in the clinic, helping us and guiding us with our cases to make sure they went well and giving us tips and pointers. And then they would work outside at their own clinics or with other companies as clinicians. So talking to these faculty was very, very helpful for me to see where I clinically wanted to be. Okay, so my journey in terms of my career is what I want to discuss next, because I have worked for many, many different kinds of work environments already as an endodontist. I started by working at a large corporation with multiple offices spread apart through the state of Pennsylvania. Not sure why I did that, but that was my first job. Then I went into a group practice. I also worked part-time at a multi-specialty dental offices. And finally, all of that led me into believing that ownership was the right way for me. So I opened up my own office 3 years ago. But let's discuss the first one, large corporations. These are getting more and more prevalent in dentistry. They're already very prevalent in medicine and other fields of healthcare, but dentistry is, I think, the one this is the least prevalent in. But from what I learned over here in terms of interacting with staff members and other dentists, I did not like going to 10, 15 different offices a month and not feeling like I was part of the team. I wanted to be in a place where I was settled down, really committed to that office and its patient base. So while this was not a great experience for me, it did help me figure out what environment works best for me. And even when you become whatever you want to be professionally, you're going to continue to grow. Your environment's going to shape who you are. You may even change all of your opinions and what you thought you wanted to do. So continue doing that, explore your options until you are actually happy in your career. So large corporations was definitely not for me. I next joined a group practice with, there was an owner endodontist and me and another endodontist as well. So from what I learned over here, yes, I respect the guy. I think he's a great endodontist, but I did not appreciate his style of talking to patients. So just observing him, looking at him talking to patients and seeing how they reacted, I could see that even though his work might be fantastic, patients were not necessarily as happy as they could be because his communication skill was lacking or he just wasn't putting in the effort to communicate properly. Moreover, he was not very it wasn't a very team atmosphere at the office. My personal belief is that everyone at the office is very important, not just the endodontist, the dentist, or the healthcare provider. I think every member and part of the team has a very specialized skill set to offer, and we have to treat everyone with respect for that. So we each have our own formula for success. The one that I found at this group practice was not for me, but I am thankful for being at this work environment because it taught me what I wanted to do at my office. Before I did that too, I also worked for a while at a multi-specialty offices. There are quite a few of these as well. Multi-specialty offices typically include a dentist that does what they do best, which is restorative work, which is crowns, bridges, and implants sometimes, but mostly crowns and bridges and fillings and cleanings. Everything else they refer to the specialist, but the specialist is in office. So the specialist may come to your office once a week or once every other week, and the patient waits for them to come in. So that office has a dentist. It had me coming in once a week. It had the oral surgeon coming in once a week for extractions and other reconstruction procedures. It had the periodontist coming in for implants once every other week. Had the orthodontist coming in every Saturday to see patients for that. So that's what a multi-specialty office is. I don't necessarily like that atmosphere because, again, it certainly cannot be a full-time job for a specialist like us because one dentist cannot provide enough work for this many specialists. And therefore, I did not feel like I was at home at these offices. And also, when you have that few cases to do, there is a lack of diversity of cases. And at some point, that gets very repetitive as well. So moving on from all of that, the path that I eventually chose for myself was ownership. I opened my office up 3 years ago. I briefly touched base on why I chose to open up my own office. The main reason was because I like to control all the factors that not just patients would appreciate, but also what my staff appreciates, what I appreciate about myself, and what my referring dentist, which is actually my actual customer, would appreciate. So I applied what I have learned from all of my experiences. I'm very happy for all these experiences. I encourage you guys, again, to experience and explore before you just commit to one thing. Initially, when I started working at the large corporation, I thought, this is not going to work for me. I hate it. I need to buy my own office. So for 6 to 8 months, I tried to buy my own office, and the deal did not work out, which is a blessing in disguise. But don't just force yourself into one thing. At least give yourself a little bit of time to explore all of your options before deciding what works for you. While ownership works for me, it is a lot of work. Maybe you want to just work 3 days a week and commit and focus more on family. Maybe you want to just go in to the multi-specialty office, do what you have to do, and have to worry nothing about administrative work or anything like that. So it depends on really what you're looking for. Or maybe you like traveling to 5, 6, 7 different offices in your city. It's a different environment every day. You enjoy meeting up all your friends as staff once a week, and you enjoy seeing the diversity of cases. That's perfectly fine as well. Whatever works for me may not work for you. So my point is, please explore. Give yourself the time to do that and then commit. That works for your education, and that same advice works for your career path. You want to be happy with what you're doing, and you will only know that if you spent the time exploring it. So next, I want to talk about what a typical day is like at my office. I don't have many good pictures because my office is, we just moved from our old location only 10 days ago. So we're still setting up. It's a bit of a mess, but I do have a couple of pictures. So my office is called Greater Maryland Endodontics. We're located in Hyattsville. We're just north of the capital, Washington, D.C. So we see patients from both the state of Maryland and the District of Columbia. So let's go into a little bit more detail about what a typical day is like. So as I said before, I mentioned to you guys that I find the most important or distinguishing factor for an endodontist to be the exam, the diagnosis, or what we call the consultation. So even if the patient comes in, which many of them do, insisting that the dentist told them what's needed, they just want me to address it, I am the specialist. I am not just going to treat something I haven't necessarily been exposed to. I will do a consultation. It's required for every single patient in my office. So because diagnosis is the key to success, as I mentioned, for good treatment outcomes. One of the most important things that many of us as clinicians in all of our fields don't do enough is first starting by listening to the patient. The patient doesn't know all of the important terms and stuff that describe what's going on, but they have a lot to tell you. They have a lot to tell you about the history of where, why something is an issue, what they're feeling, what they think is the problem, where they think we should focus. So typically I first gather that. And the important part is, even if the referring practitioner, the referring dentist has something wrong or is not correct, you want to respect them. As specialists, they are our main customer. It's not the patient, it's the dentist. The dentist will send us more cases, more patients again and again if we respect them, if we treat their patients well, if we send their patients back with good results and with a smiling face. So the like I said, our customer is the dentist in this case. It's not really the patient. So make sure you cater to the patient and the dentist as well, but always stick by your rules. Be in control. If you think a consultation is required, yes, it's required. If x-rays are required, yes, they are required. If an exam is required, if further testing is required, all those things, you want to make sure you control that. You are the clinician. You are working for the health of these people. You do not have to do the work. You must do exactly what you think is required. Next step after the consult, if the root canal is required, start with informed consent, discuss that with the patient, make sure that you've answered all their questions, they realize what they're actually consenting to on a basic level. As I said before, pain management is very important. Many of the patients that I see are in severe pain. Some of them have been in pain for weeks or so because my schedule is busy. So you really want to respect that and make sure that they are very comfortable. You are the pain specialist. We do want to make sure we have adequate anesthesia. We want to give them that time to get numb and be comfortable and test it before we actually start the procedure. What we use in endodontics to get a very clean field is rubber dam isolation. It is basically the standard of care at this point, so it should be done for every root canal. If you see that tooth over there, before the tooth is actually opened up, we isolate that tooth with a rubber dam. So that contraption you see around that, the metal clamp holding the plastic or the material in place and sealing it from the outside oral fluids is called the rubber dam. The reason for doing that is because when we clean the canals and disinfect everything, we want to make sure we have a clean field. We do not want contaminants or irritants going back in those canals and contaminating the bone again. So that's why we do that. And the second reason we do that is because the instrumentation that we use, the files are very, very small. They can very easily go into the patient's throat. So it is also for safety reasons. So the first thing we do after rubber dam isolation is the access preparation. So it's a very important part of the procedure. We clean out the cavity or the crack or whatever it might be. But the main thing we do is we access the pulp chamber. The pulp chamber usually has more than one canal, unless it's a front tooth, to locate all of these canals and be able to predictably and satisfactorily clean the anatomy of the roots. We need to have good access to all the roots. So if you see this particular case over here, this is actually not a picture of my patient. It's from the internet, but it's a well done access preparation. The entire cavity has been removed, so bacteria is not going to go leak back into the canals. All of the canals have been located and the instrumentation can go straight in there and clean out the canals at this point. So that is a good access preparation. Once the access has been prepared, we use, which we do under microscopes, but we use microscopic endodontics. So if you look at this picture in my office, the dental chair is right there. And it's not the best picture. Like I said, my office is a bit of a mess right now. I apologize for that. But this is a microscope. Once the patient is lying down, that microscope's pulled up towards me, and I'm able to see the tooth in a very large field. It typically looks exactly this big, and I'm able to find all the canals and disinfect everything, versus the tooth looking really, really tiny with the dentist using just their loupes or even their naked eyes if they're not even using loupes. So that microscope definitely has helped make treatment outcomes much more predictable. That is one piece of, if you don't see an endodontist with one, you probably should not be going with them. They're not very updated. Let's briefly discuss what the root canal procedure goes like. So the goal of the root canal procedure, again, is to remove the diseased pulpal or inside tissue. Once we remove that tissue, we disinfect the canals, and we fill that with a root canal filling material. So if you look at the tooth before it's been touched, on the very left side, there is a large cavity. The cavity is clearly contaminating the nerve space, so patient is likely in pain or has an infection. You can see that there's possibly even some periapical destruction, some abscess at the very bottom. So we're going to make a nice access preparation, remove all that contaminated hard tissue, and get into the pulpal space. We're going to use instrumentation. We're going to remove that diseased pulp. Then we're going to irrigate and clean out the tooth, which is the third picture, disinfect everything. So to be able to make sure you're able to go all the way down inside the canal and disinfect everything, you have to shape it correctly. To shape it correctly, you should be able to access it correctly. So then picture 4 is where the root canal filling material has now been placed. So as you can see, it only goes up to the end of the root. It does not go past it, because we don't want to cause any contamination into the healthy body tissues. We want those tissues to grow back. And the root canal filling material stops where the gingival margin is, because on top of that, the dentist is going to place a filling or a crown to seal it for aesthetic reasons, aesthetic and functional reasons. Okay, so so what I just discussed, here's a before and after of a case that I did a couple of weeks ago. The top radiograph is actually two teeth that we can focus on. The tooth that already has a root canal filling material in there at the very center. As you can see, there's a crown. That white part is a crown material, and there's a gap on the right side where it's leaking. The root canal filling material is very sparse. It's not really going all the way down the root. When I redid this or retreated this case, I made a hole through the crown. I cleaned out the previous filling and also the root canal filling, disinfected all the canals to the very end of the tooth, and then placed root canal fillings in all the canals, all three of the canals in this case, to the very end. Now the body can heal around it correctly because filling material is not outside, it's not causing any contamination, and it's also not short of the end of the tooth, so bacteria does not have room to grow again. Okay, so let's talk about some cases. Excuse me. So one of the reasons, as I mentioned, to see an endodontist to get predictable results is difficult anatomy. Typically, cases might be curved, might have long roots. In this case, this is a very curved tooth. 42-year-old female. She came with extensive caries, which I removed, as you can see the filling material over there. And she had severe, severe throbbing, radiating pain. So she came in as a same-day emergency because she just could not even go to sleep. So we got her extremely numb. We removed the cavity, removed the pulpal tissue, and cleaned out the canals. Now, it's not very obvious to see in a two-dimensional X-ray, but that front root, the right root, is extremely curved. The other root is very, very long. So I disinfected everything and went a little bit short of the end of the root because I did not want to break any instruments there. So if you just jam instruments there, not realizing what the anatomy is dictating, you may break an instrument. If you break an instrument in that tooth, that is very hard or impossible to retrieve. Moreover, if you break an instrument and block the path of cleaning, then you are not going to be able to disinfect the tooth correctly. The patient is eventually going to not heal. So that is one reason. Another reason, as I mentioned, is traumatic injury. So here we have a 14-year-old male. He came in actually last week from Children's National. These two front teeth that you see braces on at this point, this was a sports-related trauma, sports-related subluxation, meaning the teeth moved and probably caused some injury up and towards the roots where the nerve goes into the tooth, because within a week, he started to have severe pain. And when we tested these teeth, the nerve tissue was already dead for both of these teeth. So our goal, for multiple reasons, was to do the root canal. We did the root canal, cleaned everything out. If we do not do the root canal and stabilize these teeth in place, eventually he is going to lose these teeth. When cases are traumatized, more than likely the body starts to resorb these teeth, to absorb them, and eventually they just sort of fall out. So when the teeth are missing and the child is still growing, we do not address it correctly, the bone does not grow correctly around these teeth in the alveolar process. So that is one reason to do the root canal correctly. It's to manage bone growth of these patients. And because it's a trauma case and we want to make sure things heal longitudinally over time, most of the patients that I see that are under 18 and are still growing, I tend to see them for many, many, many follow-ups to ensure that everything continues to heal and reinfection does not develop. Because if it does, which it can, we need to address it quickly to make sure they continue growing correctly. Another case that I've already briefly shown you guys is endodontic retreatment. We do see many, many retreatments that are done by both dentists and endodontists, and they need to be redone. In this case, if we look at this patient, I'm going to discuss two different teeth. The one that is towards the right side is a first-time root canal with a large cavity. The cavity is removed, tooth's cleaned out correctly, and the root canal filling is placed. The second tooth is an endodontic retreatment. In that retreatment, there are multiple reasons for failure or non-healing of that case. One of them is, as you can see, the crown restoration, which is the large, really, really white restoration, has a gap on the right side. That gap is clearly causing leakage of material over time as saliva and bacterial contaminants continues to leak there. That root canal system is going to get reinfected, and it's going to cause bone abscess, which is what he presented with. Another reason for failure of first-time root canal treatment is the lack of filling all the anatomies. If you look at this case, the picture at the top has two really flimsy root canal filling materials there. They're short of the end of the tooth, so clearly there is space for bacteria to invade inside the tooth structure. And if you look at my x-ray at the very bottom, the root towards the left has two canals filled versus just one filled at the top. So my goal was to clean out all the previous root canal filling material to the very end, disinfect all the canals that I was able to locate to the end, and then in this case, unlike the previous time, fill in all the anatomy correctly to prevent future contamination. Now that that's done, the patient can now follow up with the dentist to have a new restoration placed to make sure my work does not leak again. So again, reasons for endodontic retreatment. One, extensive caries. If caries is really, really large, yes, a root canal could be beautifully done, but if it continues to leak because of a new big cavity or a deficient restoration, inevitably, ultimately, that root canal procedure is going to fail. It is going to get contaminated. Another reason is despite everything looking like it's done beautifully, the infection remains resistant. There is periapical pathology, meaning that the bone around the tooth, around the periapex, around the apex of the root, continues to not heal. There is continued infection, there's continued symptoms. So we have to go in again and disinfect everything all over again. So that is one reason as well, or which of course can lead to buccal swelling if there is an acute abscess. And as I mentioned, the last reason, poor obturation or poor filling material. So what we call our filling material is the obturation. So poor obturation, as we see in this case, is lack of sufficient work done. So we just have to, without criticizing the previous dentist, communication is important. We clean everything out, disinfect everything, and redo the procedure. So that is one reason for endodontic retreatment. So that is pretty much all I have for you guys today. I am open to questions. Thank you for listening to me.
Thank you, Dr. Khaliq. My name is Robin. I'm a third-year PhD student in the Johns Hopkins School of Medicine. I'll start off our Q&A. How long is the dental residency for endodontics?
So typically, most residencies for endodontics are 3 years. There's only, I think, 4 programs that are 2 years long. So I would say plan on being there for 3 years. Now, unlike most medical residencies, it is not expected or guaranteed that you are going to match into residency right after dental school. The vast majority of dentists are actually general dentists, 90% of them. So only about 10% of us specialize into these 9 specialties. And many of us do it after working for a few years as a general dentist and deciding, hey, that's something I want to do. And then we go back and do that. So many of us don't do the career path that I chose in terms of going directly into it. So just expect that difference.
Okay. What would you recommend is the best diet for a healthy mouth to prevent infection?
So a lot of patients that come in, I think America's diet is particularly bad for teeth. a lot of the reason for that is that one, a lot of refined sugars are there in most of the things that we eat, and that produces acid. The other reason is our lifestyles and habits. So yes, I'm not going to say I never have any sweets or sugars or juices or sodas, but typically when I have them, it's the time of exposure to your teeth. So if I'm going to have dessert, I'll have my dessert, and then I'll brush and floss afterwards. And then for the next 5-6 hours, my mouth is without all that acid and insult to the teeth. Versus somebody who's continuously sipping on iced tea all day at work, and there's sugar in their mouth all day. And then they go home, they don't really floss, they're tired, they go to sleep. So if you have 24 hours of exposure versus, let's say for me, 5 minutes of exposure and cleaning it out, it really makes a difference. So yes, you're going to have all sorts of foods. It's important to pick foods that are healthier for you. But one of the biggest things that we can do, especially with children that we see, is tell their parents, we know they're going to have this stuff, but you can certainly structure eating times for them and then make sure that hygiene is important after that so that their exposure time is limited. Most of our cavities happen not because someone had something sugary, it's because they had sugar or acid in their mouth for the whole day.
Definitely something important to keep in mind. Speaking of children, what's the youngest patient that you've had to perform a root canal on? And does a pediatric patient cause a more complicated procedure?
Yeah, so we start to see children with permanent teeth at around age 6. So before that, we don't really see patients for root canal procedures, because root canals are typically to save permanent teeth. So the youngest patient I've seen is about 6 or 7 years old. And yes, it's a bit more difficult to manage them. Sometimes you provide sedation, nitrous oxide, things like that to calm them down. But the most important thing is communication. So when I speak to a patient, I usually don't have the parent there, because parents usually end up, they're overprotective. They know their kid's been in pain and so, and they end up actually saying, oh, what's going on? And, they'll interrupt when the kid should be able to speak. So I'll speak with them, let them know, you'll feel a pinch. It's going to hurt a little bit. I'm not going to lie to you. I'm here to be honest with you. I'm not going to hold you down. I'm not going to force anything. But there are multiple ways of dealing with this. One way is you're in severe pain right now. You go to the hospital, you lose your tooth, and that's very traumatic. Or I can be here with you. I can hold your hand. It'll be a 5-second pinch. We'll give you a shot. And after that, it's totally painless. We'll clean everything out. Just trust us. And the vast majority of patients who are kids respond to that. But yes, it is a little bit more talking, communicating with them, and managing them. Yes, adults require that management too, but it is particularly a little harder with kids. Now, in terms of procedures that we do with kids, sometimes the root is not fully developed, as I mentioned, and if that's the case, we have to change our approach. We can't do it in one session. It has to be multiple sessions where we place material inside the tooth to encourage further root development. There's multiple procedures for that. It's kind of extensive: apexogenesis, apexification, all that kind of stuff. But our goal is to see them in multiple visits and slowly help the root grow over time to make sure their bone grows as well. So it is a little more involved with them, because their anatomy is not as predictable, because they may or may not be done growing for that particular tooth.
What are the different anesthesia options for these procedures? Do patients have any say in what they receive, or does it depend on the procedure itself and the age of the patient?
So it mostly depends on, one is their health status. So patients who have cardiac issues or patients who are pregnant, typically we only use local anesthetic in terms of lidocaine, because lidocaine is the one that's recommended for pregnant patients. But the dosing depends on your cardiac status. So patients who have had a history of myocardial infarct or things like that, we do require a clearance from their physician, and their physician typically determines the maximum dosage we're able to give them. As I mentioned, the main anesthetic we use is lidocaine. It's always local anesthetic. Yes, we do give sedation for certain patients, but that's the main one that we use. We also use mepivacaine or carbocaine, which includes no epinephrine. Sometimes that is what we use if we need additional anesthesia for patients who have risk factors in terms of heart disease. But because there's no epinephrine there, it lasts a very short time. So we only use that if we really need to get them numb. The last one that we use is Septicaine. Septicaine has a higher rate of complications, especially with lower block injections. So I prefer not to use it unless I really have to. It does work really well, but again, higher risk of complications, especially for lower teeth.
So a question from pre-dental students: how did you prepare for the DAT? Do you have any tips for students currently studying for it and applying to dental school in the upcoming cycle?
So that was a really, really long time ago. I know it may not seem like, to me, it seems like a very, very long time ago that I studied for that. But I took the MCAT and the DAT. I was happy with my scores on both. But it's basically focusing, right? Like, it depends on what your study style is. My study style is I'd like to be in a room by myself for a couple of hours, achieve something, and then take a break. So a lot of us finds issues with focusing. My thing is, I'll tell myself, I'm going to do this for 10 minutes. And I usually end up doing it for 30, 40 minutes if I do that. If I tell myself, okay, well, today is study day, I got to study all day, I'm probably going to stay there, nap for a while, take a shower, watch some TV. So just whatever you're doing, put it in manageable increments and you'll outperform yourself. That's one thing I would say. The second thing for the DAT in specific, I think it's a little more difficult in certain parts than the MCAT, but a little easier in certain parts. The DAT, I don't know if they still have this section or not, but they had a section which was your perceptual ability, which is something that you really, really just have to practice to get better. Because as dentists, we really have to imagine the three-dimensional space around the tooth to be able to work correctly and produce good results. And that section is testing that. That is just a skill you have to just practice and practice and practice. Everything else on the DAT is basically I would say, basic sciences. So that's just knowing your material well, and you'll do well.
Of the types of cases that you described, what would you say is the most challenging type of case? And do you ever have to collaborate with other types of specialists?
So the most challenging type of case are certain types of retreatment cases. Excuse me. We don't see them very often, but sometimes the filling material that is placed inside the roots is very difficult to remove. So like, for example, in Russia and Eastern European countries, they use a material called the Sargenti paste. It's basically like rock when you're getting packed into it. So yes, they've done their work, they're happy with it, but they don't consider the next clinician that may have to go back and clean it. So when I go in there, it takes me multiple hours to get through everything, clean everything out. So that's a difficult kind of case to do. It's mostly retreatments. With first-time root canals, they may be difficult cases. The anatomy might be difficult, but I'm the first person touching it. I have a technique. It's very predictable. I know what to do, so I'm happy doing those. I would say it's retreatment where I don't know what the material is that sometimes make me feel like, I don't know how long this is going to take. I don't know what's going to entail, because we don't know what the dentist did. And usually by the time the patient sees us in 6, 7, 8 years after the initial case, they're no longer with the dentist, maybe not even the same state or country. So we can't really establish a good history of that. And in terms of collaborating with other specialists, communication is very important. So every patient that comes in from the general dentist, once we've diagnosed them, if there is something we've diagnosed that the dentist does not think is the case, we always call them back and confirm. And they usually just say, yes, doctor, I understand. You know what you're doing. And this is I was just suggesting something. So, but it's still important to respect their field and give them a call back. So that's one thing that we do. The second thing is, once we do our work, sometimes we see the tooth is so broken down that it may not be savable. So what is the point of doing a root canal when the patient's going to go back? The dentist will say, oh, the root canal is done, but I can't really save this tooth. It's too far broken down. So if you are seeing that questionable restorative, you want to touch base with the dentist or the prosthodontic specialist that referred them to you to make sure that it's still savable. So that's another reason to collaborate. The last reason to collaborate is with, for example, pediatric dentists. So the Children's National Hospital that sends patients to us, there is a pediatric dentist there that is initially managing the trauma, and then they're working with us to make sure the infection completely heals. So we communicate with them again and again to make sure the patient is still stable, still doing well, still growing. And that also goes to the orthodontist. A lot of patients are sent to us from the orthodontist because the orthodontist may notice that there's something off, patients in pain from this tooth, there's some resorption, there's some trauma, and we continue to update them on what we're doing. And we may ask them to stop because orthodontics is very aggressive. If the tooth is already damaged or traumatized, you do want to stop orthodontic treatment until you stabilize the tooth and address the infection and bone pattern.
Do you have time for like 2 more questions?
Of course.
Okay, so this one's from Jasmine. She wants to know what helped you narrow down the schools you applied to for dental school. What was your biggest guiding factor? Was it location, finances?
So 2 things guided my main reasons. We all have our own reasons, but one of them was being close to family. So I did not get into University of Maryland, where I'm based from. So my next closest school was University of Pittsburgh or, somewhere in Philadelphia. So I chose University of Pittsburgh for 2 reasons. One, because I had a lot of family and friends there, and it's a good support network. I'm not living with them, but it's good to be able to have that. It does help you focus a little bit better. The second reason for me was the diversity of experiences it offers. Pittsburgh is a very good school in terms of its research ratings and also its clinical ratings. So I wanted to make sure that wherever I went, it was an established school where there is a research program in case I wanted to do that, or there's a big clinical focus. So being in the inner city, seeing a lot of patient volume, that was one reason I chose that school. Wherever you go to dental school, you're going to be successful as long as you are willing to progress and ask questions and be upfront about your goals. So there's always people everywhere you go who are very good at what they do. So the whole school might not be amazing, but there's going to be that faculty member who wants to help, who knows what they're doing in their personal life, their career life, and they're more than willing to sit down and talk to you. So even if you end up being somewhere where you don't think is amazing, I encourage you guys to reach out of that comfort zone and talk to people who are in the profession, who are doing something that you think you might love doing.
And before our final question, I just want to thank you again. Your talk has been so clear and informative. I finally understand what a root canal is.
Thank you.
For our last question, would you say that your field allows a pretty good work-life balance?
Yeah, so I think it just depends on what you want to do, but our field definitely does. The one reason that I chose endodontics beyond just enjoying doing root canals was because I did not want to work at night. My mom is a physician, as I mentioned, and seeing her work hours, I was like, yeah, I like healthcare, but you keep that to yourself. I don't want to do that. So endodontics, unlike some of the other dental specialties, does allow for that. For example, if you have oral surgeons do work at night. They work with hospitals. Dental anesthesiologists do the same thing. They have odd hours. They have long procedures. For us, we basically pick our work life. You can work with a big company and they might dictate your schedule, which I hated. So I just chose not to work there. You can work at a group practice where you have good communication with the main owning dentist or doctor, and let them know what your work hours are. You can cut your time to 2-3 days a week and work like that. Or you can open your own office and you can see as many patients as you want, 6 days a week, open up like crazy and earn lots of money. Or you can do what I'm doing, which is I basically work 4 days a week. I could work more. There are patients are there, business is really, really good. But I choose to say at some point, quality of life is important. You have to say no. So my work hours are 8 to 3. After that, there's a bit of staff management required, and then I'm done. So whether you're the owner or you're working for somebody, this is a really good field to be in. Once you figure out what job works for you, you can either work only a couple of days to make sure you have that work balance and set expectations, or you can open up your own office. And yes, for the first 2 to 3 years, you may have to work a lot to establish your business. But once you're in the flow of things, you're respected where you are, people want to refer to you, you can say, well, this is how much I want to work. And if there's somebody else after that, I don't have space for that. Like at some point, you do have to say no. You have to think about your life as well.
All right, thank you so much for giving us your time today.
You're welcome. Thank you for having me.
Thank you so much, Dr. Khaliq. We truly appreciate you taking the time to answer all of our questions and going through this really detailed session. And I'd love everyone to please give a warm thank you to Dr. Khaliq in the chat box for this incredibly informative session.
Thank you. Thank you for having me.
Sorry about that. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. And again, you'll need a 70% or higher to pass and receive certification. And that link is in the chat now. And many of our students have expressed interest in pursuing a leadership position in teleshadowing. And so we have reopened our leadership application for students interested in joining our team as well. And that link is also in the chat. And now on to our next session dates. So our next session will be next Friday on January 28th at 10 a.m. Eastern Standard Time. And also, as we reach our 1-year anniversary in mid-February, we'd like to announce that our first ever physician mentor, Dr. John Green, will be joining us again on Friday, February 18th for another session. So thank you so much for everyone for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing session.